I think, Dr. Munir, we have also non-Arab attendees, so we can start speaking English now, I think.
Yeah, sure, definitely.
Yes, yes.
No problem at all. Obviously, good evening to all attendees. It's a pleasure to have you all here, and we'll start very soon. We're just waiting for Dr. Mazin to join us, and then we'll start.
So, Dr. Munir, I shall ask you, your expertise in the oculoplastic and in the cornea. Does it help being a glaucoma specialist? I mean, does like the wound healing and those things in cornea? Do you apply such things in the glaucoma surgeries? What do you think about it?
Yeah, absolutely, actually, because it comes together. It's very handy, especially the oculoplasty and the cornea. It fits perfectly with the glaucoma subspecialty because in many cases you ignore the ocular surface disease and you ignore the signs patients are having after using the drops for many years. And for me, I'm really a big fan of the ocular surface disease. So I try my best always to have white eyes for most of my patients. Sometimes it's not possible. And it's very handy because, I mean, I have another colleague in the department, corneal specialist. So I try always he always keeps telling me, you are really kind of helping me a lot because I try not to refer patient. I try to treat in-house. But if you have very obviously refractory case, you have to refer. I think the other thing is if you have this joint experience, it's always fascinating to look at the tiny signs and try to observe the healing process. Even after the surgery, it comes very handy when you are treating or doing the follow-up and trying to remove the stitches, trying to, try even to, when you do the technique, the surgical technique, if you pay attention to specific signs, it makes a huge difference. But yeah, it's nice experience. But I wouldn't claim that I'm cornea specialist, not surgical specialist, because I did very limited surgery. But yeah, I spent 5 years with Prof. Dua mainly in the clinic, which was obviously very great experience. But it was really good experience, but not surgically. I wouldn't claim having this surgical experience.
Anyhow, I think if we have the time, we can discuss such cases today. If we have the time allows, how to. I don't know if it's related to the today's topic, but preparing the patient to the surgery is the most important step in the surgery, I think.
Absolutely,
So
absolutely.
I think I
mentioned about this, and from now till Dr. Mazin join, I can at least start talking about the main idea of the first couple of my slides. I think as we discussed, Dr. Basel, before, the unique thing about the glaucoma surgery is you are trying to treat patients who, from his point of view or her point of view, they have no problem whatsoever. You are trying to convince them to go to the theater, do major operation on them, and then obviously trying to save their eyesight. So the trust which you need to build with the patient and the relationship is really the most important thing. And the other thing is, I think it's very important not only to think about the surgery, because a lot of things, as you mentioned initially, you need to think outside the box. So you need to prepare the patient, not only preparing the eye for the surgery, preparing the patient psychologically, and ask for support from the family, ask for to make sure that they will be able to use the drops after the surgery, they will be able to come for the follow-up. Otherwise, there is no point really of doing the surgery. Hi, Dr. Mazin. Salam. We can't hear you. I think you are muted.
Salam
Yes.
alaikum.
Alaikum salam.
Let me allow. Salam alaikum, Dr. Basel.
Alaikum salam wa rahmatullah. We chatted a little bit about glaucoma, oculoplastic, cornea. You know, it was a very nice discussion with Dr. Muneer, who has expertise in this fields as well. So, yes, and it's related to glaucoma by way or another, you know.
Yeah.
Jazakumullah khair, and I'm very sorry for being late because I've just reached from the clinic almost 15 minutes ago. So are you ready, inshallah, to start?
Yes, we are ready. So first of all, I'm just trying to open the slides.
So let me welcome you both first, and welcome the attendees as well. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody to this session of the glaucoma series. By the way, this is the one before the final one, because the final lecture will be in December, and that will be the end of the glaucoma series. And next year we will start with other subspecialty, inshallah. But maybe we will do some events, like full day event in glaucoma, and we will announce about that. Inshallah, of course, Dr. Basil as well will be with us this time as a speaker, inshallah, and new speakers will be on board as well. So today we are delighted to listen to Dr. Muneer to talk about the practical tips in trabeculectomy surgery. By the way, I used to do trabeculectomy in those old days, and as well Ahmed Valve, but I stopped because now I respect the subspecialty very much. I refer every patient with glaucoma to the glaucoma specialist, and I have started doing this maybe 8 years ago. So I stopped doing any glaucoma surgery about 8 years ago. And because I believe that the patient should take the full care in terms of surgical skills, and at the same time, which is most important, is the post-operative follow-up, because it is not only a technique, but how to follow up the patient and how to treat any complication. It is just like the refractive surgery. If you are not well trained in refractive surgery, either you find a way to be well trained, or you have to refer to a refractive surgeon. And the same can be said about any other subspecialty, because it is not only I have to prove that I am good and expert, but as well you have to think about the patient as if you were the patient, or your daughter were the patient, your mother were the patient. So now the stage is yours, Dr. Muneer, and thank you, Dr. Basil, for being with us to moderate the session.
Thank you very much. Thank you, Dr. Basil and Dr. Mazen, and for all attendees. It's a pleasure to be with you again today. Can you see my slide?
Yes, we can.
Okay, yes. So obviously I was planning to talk about practical tips in glaucoma surgery in general, but then I decided to go and focus only on trabeculectomy, mainly because if you are good surgeon and you do proper trabeculectomy, you will definitely be a good surgeon in any glaucoma surgery, no question asked. Trabeculectomy is the most difficult surgery, and I think not only in the glaucoma subspecialty, possibly in most or if not all subspecialty in ophthalmology. So I thought just to spend like almost 1 hour to focus mainly on trabeculectomy, and a lot of things which we are going to mention can be applied on all other type of glaucoma surgery anyway. So the main topics will be introduction, literature review, and then practical tips, slides about trabeculectomy surgery, followed by video to summarize the whole thing, and then conclusion. The sources of clinical information in this presentation: from literature, from conferences, from mentors and colleagues, many thanks to Prof. Keith Barton, and from own mistakes. I started doing trabeculectomy. I did my first trabeculectomy in 2006. And obviously, I faced a lot of issues, a lot of complication I dealt with, and that's how you can build your experience, I think, not only the literature and the conferences. So first question, always I think we have to ask ourselves, why do we need to do trabeculectomy? What is the reason for this surgery? Obviously, the answer could be very clear: progressive, moderate to advanced glaucoma, when medication alone are not enough or cannot be used for any reason. And according to the RCTs, the randomized controlled studies, these are the figures which you are getting. And these are three of the very important studies, obviously. The mean IOP reduction with maximum medical treatment is 17 millimeter mercury. Mean IOP reduction, or mean IOP, I mean, with Preoperative or tube, both together, between 14 to 15. However, with the trabeculectomy and Mitomycin, it is between 11 to 12. So this is the acceptable worldwide numbers of the average IOP after these kind of treatment. So there is clear evidence that if we operate on a patient who has progression at early stage, they will do really much better than people at very late stage. So in other words, if you choose to operate on a patient with very advanced glaucoma, after you ignore it for many, many years, whichever you do, they may still go towards the blindness. But if you choose to operate on this patient while they are progressing at early stage, so they will do reasonably well. And the recommendation from the literature is very clear about these things. So with the primary open-angle glaucoma, if you have advanced to terminal glaucoma, you have to go to really low pressure to be able to maintain the vision. And exactly, even more in the normal tangent glaucoma, even you need to go to less than 10 millimeter mercury. And if you compare these figures with the literature, you can really tell why do we need trabeculectomy in such cases, and why, for example, Preoperative or tubes alone may not be enough. The first thing we think about when, or I think about when I have a patient who needs trabeculectomy is the case selection. Case selection simply means trabeculectomy doesn't work for everyone. Otherwise, I would have offered this to every single patient. So the success pathway has elements. And the elements are, first of all, as a surgeon, what is your threshold to operate? And I used to have really low threshold to operate. I used to offer trabeculectomy to patients, kind of very elderly patients who are having slight progression. And then obviously I had many issues myself. So I learned from my mistake. Now I'm having, or my threshold to operate trabeculectomy is a bit higher. I can accept, for example, some progression, let's say in case like this, who is progressing on the OCT and progressing on the field of vision and age of 80 or 85 plus, I would happily accept this because according to my calculation, he will not have visual disability during his lifetime. However, in cases like this, for example, or like this, which is not typical for glaucoma, but this is just for the sake of argument, or even any case where there is involvement of the central vision, 10 degree central vision, or if the lower part of the field is affected more than anything else, more than the upper part, or if this is obviously very advanced tunnel vision, and if the age is not really kind of, we're not talking about very elderly patient, I would definitely offer the trabeculectomy as a first choice. The case selection, as we said, so we need to think about the age and the progression rate. And if we think the age, or let's say the progression will not cause blindness during the lifetime, I wouldn't offer trabeculectomy for a patient during their lifetime because of the risk of complication and risk of obviously other issues. I will show you later why, obviously. The other factors, you need to think about the ocular factors, systemic general health and medication, and social factors. So ocular factors are obviously obvious. The risk for any failure after trabeculectomy could be previous surgery involving the conj, scarring, using a lot of medication, mainly pilocarpine, in addition to brimonidine and bimatoprost for many, many years, because these are the worst in terms of scarring. In addition to the type of the glaucoma, mainly uveitic and neovascular glaucoma, in addition to aphakic glaucoma. The systemic general health, again, it depends on the medication and the immune status of the patient, how well they are. Are they at any risk of having infection post-op? Or do I think that they can cope with this major procedure? And the most important thing is the social factors. I mean, luckily, in some societies, like, for example, where I came from in Syria, we don't have this as an issue as such, because socially, most people, they have a lot of members of the family who can take care of them after the surgery. But here in this society, for example, in the UK, this is a very important factor, because those patients, they will need to use a lot of drops for 3-4 months, and they will not be able to see properly initially, and they need someone to take care of them. If there is no one to take care of them, no one to bring them to the hospital to have the follow-up, there's no point of doing the surgery, because it will fail and it will make things worse. So these things are definitely under the case selection, in addition to the race and the age. As we all know, the Asian or the Afro-Caribbean people, they are at much higher risk of failure compared with other people. And the same applied for a young patient, especially juvenile open-angle glaucoma. The other element for success is you need to develop your own perfect or sound surgical technique. And that's what we are going to talk about in this presentation. And the post-op follow-up, what we do after the trabeculectomy, it matters actually, in my opinion, more than the surgery itself, because you can always have this kind of shaky hands, and you can kind of do near perfect trabeculectomy, and you can obviously still have very perfect outcome if you have perfect post-op follow-up and you know exactly what you are doing. But the opposite is not right. And finally, you need to manage your and the patient expectation. You need to define what is success. Success, it doesn't mean that the patient will have 6/6 vision, perfect field, perfect pressure, no change in the OCT, and patient will be happy and everything like this. This is not phaco, unfortunately. This is trabeculectomy. So in these cases, you need to tell the patient and explain about the risk. The most common risk, obviously, it can be repeat surgery if the pressure is up or down. Vision will be blurry. Most patients, they lose 1 or 2 lines after the surgery, and they have to accept this as a compromise. And they may have astigmatism, they may have cataract, they may have other complications. So you need to tell the patient about these, and it's up to the patient to choose if they have capacity. I always tell my patient, if you have complication, you will lose the vision within 1 week. Whereas if we don't operate, you will lose your vision within a year or 2, for example. But it's up to you. Complication is, at the end of the day, it's rare, but it can happen. And you will be surprised, because if the patient has capacity, many of them, they may choose not to go ahead with the surgery because they need to know, or they need to have guarantee about the surgery. No one can give guarantee in such surgery. So that's something, again, you need to give the patient about it and define what is success. Success, is it stopping the glaucoma completely from progression? Is it delaying the progression, or what? And in my opinion, if you can delay the progression significantly rather than stopping it, that in itself, it can be defined as a success. This is a very interesting study, and the reason why I wanted to show you this, just to show you how things are in the real life. This is the UK National Survey of Trabeculectomy about the early and late complication. It was published in the Eye journal in 2022. It's quite recent, actually. And surprisingly, among all the participants, obviously, who were experienced glaucoma surgeon in the UK, the early complications were reported in almost half of the cases, half. And then late complication, about 40% of cases. And visual loss, it happened in almost 20% of cases. And in many cases, the patient had more than one complication. Mainly, I mean, if we go back to the hypotony, that's always the main concern after the glaucoma surgery in the early stage. Hypotony happened in almost 1/4 of cases. So these figures are talking about themselves. You don't need proof that this is not straightforward surgery. And this is not just like you do the surgery and I did perfect trap, patient will be fine. No, this is about fighting against the natural response from the body. So it's not enough to do the surgery and then say, I'm a perfect surgeon, because you may do perfect surgery, you may do your best during the follow-up period, but still you have failure, because that's something you have no control in, which is obviously the response or the healing process from the body. And that's what's unique about the trabeculectomy surgery. The success rate, according to the primary tube versus trabeculectomy study, which is obviously the most important, almost RCT to compare between primary tube and trabeculectomy, the success rate with the mitomycin 0.4, keep in mind this is the high dose of mitomycin, it was almost, the failure rate was 13.9 at year 1, and then it dropped to almost 30% failure rate after 3 years, and then after 5 years is up to 50% failure rate. So again, that's something we need to explain to the patient. You need to tell, look, in 2 to 3 years, in about 1/3 of cases, it may fail. And these are the figures worldwide. It's not like something unique about you. And if you have other risk factors, you need to add these obviously to the equation, and it can be even more than 30% failure rate. It can be 40% failure rate. So you need to be frank with the patient. And the risk factors, according to this study, found about, just to obviously, about the extra or the failure rate itself, it's the previous intraocular surgery, mainly affecting the conj, new vascular or uveitic glaucoma, black race, and young age. So these factors were like the highest factors, or the most kind of powerful factors in terms of the failure rate in any trabeculectomy surgery. So why not to trap everyone then? As we said, case selection, because trabeculectomy, it doesn't work for everyone. So you need to always weigh risks and benefit according to the factors which you mentioned. The other thing, which is interesting, you are doing surgery and you're exposing this patient to long-term risk of infection. Because you are doing the filtering surgery, you are applying the mitomycin, either with high dose or low dose, this patient will always be at higher risk for infection, mainly endophthalmitis and blebitis. The other risk, the other thing, obviously, hypotony. Hypotony, as we showed in the previous study, it can be in up to 1/4 of cases, actually. It's really high, significant. And hypotony can be two types, either mild hypotony, which can only cause variable vision because it can shrink the axial length of the eye, and it can cause irregular astigmatism. And this is mainly a risk in young and myopic patients. So in any young and myopic patient, I always tell them, you most likely, you are going to have lower vision than before. You will notice some deterioration in the vision, because that's your anatomy. I can't do anything about it. And they have to accept this before we go for the surgery. The hypotony can be severe, and as we all know, it's mainly the loss of, it can cause macular edema, macular folds, choroidal effusion, changes, and that can cause obviously severe visual loss. There is one more thing to consider talking about hypotony. In any patient with advanced glaucoma, where they have really tunnel vision or almost tiny island of vision left, hypotony is the worst enemy, because hypotony can cause complete wipeout, even more than high pressure. So when I'm operating on a patient with the high risk for wipeout, in other words, very advanced glaucoma, I always take a lot of releasable sutures, because I don't want this patient to have pressure of 3 or 4 day one after surgery. This could be a complete nightmare. And I always make my scleral flap thick. Thick scleral flap is protective against hypotony. and exactly the opposite with thin scleral flap, as we are going to talk later. The other thing, bleb discomfort, and please don't underestimate this, because you will see a lot of patients with perfect pressure and perfect outcome. They are not happy, simply because they are having this ocular surface symptoms and they can't cope with it anymore. So that's something you need, obviously, always to explain to the patient, and you need to expect it. Oh, that's to be added to other complications, as we all know about, like systolic macular edema, retinal detachment, all other things which can cause trouble after trabeculectomy. So that's why we don't offer it to every patient, because of the risk of failure, risk of complication, risk of reduced vision. We only offer it to selected cases. So if I show you this, for example, this is a normal patient with a normal vision. He unfortunately ended up with advanced glaucoma, and that's his vision after he ended up with a tunnel vision. So you see this patient, his eye pressure is uncontrolled, you do trabeculectomy, you end up with hypotony, and that's what you get. So it's not, unfortunately, it's not like a straightforward decision, especially if you are operating on only eye patient. So you have to really spend time explaining to them. You have to tell them all about the risk, all about the benefit. And the last thing you would like to have is to have a patient like this after a couple of months of the surgery, because unfortunately they lost the peripheral vision. And now, because of you, not you as an obviously person, just because of your surgery, and you did your best still, but they ended up with almost no vision at all. So all these things you need to explain and think about before going ahead with any glaucoma surgery or trabeculectomy surgery. Before we start talking about the tips, it's very important, 2 slides here, just to tell you about the physiology of the bleb. So there are always 2 basic components which can form the bleb. The main thing is the resistance coming from the scleral flap here, which we create. And then there is another much lower resistance coming from the conj. And the conj has very low resistance, especially if you apply a lot of mitomycin or high concentration. So don't rely on the conj to really control your pressure, especially if you have hypotony. This is the key here, not to have hypotony rather than this one. So that's regarding the physiology of the bleb. However, if we are talking about the scarring, where usually, what is the most common area of scarring after trabeculectomy? This is the most common area of scarring, is not under the flap or between the scleral flap and the other area. It's above it. In other words, it's between the actual flap and the conj. That's the most common area of scarring. And the least common cause for failure or scarring is between the 2 layers of the sclera, in other words, under the flap. And that in itself is a very good reason for me or for everyone, is not to apply mitomycin above the flap, like I used to do, but not anymore, obviously. I used to do many, many years ago, but I stopped it because all the studies, they are not supporting this. There is no need, really. And if you do small flap, you will be surprised that it may not heal at all. The flap which can heal, it's usually the large flap. So large flap can heal far more aggressive than small flap. And that's why the new trend now is not to make your flap big. You have to make it smaller than usual, but on the other hand, not very small, because you don't want to lose the resistance. So what is the ideal bleb? The gravity, if you create a bleb, the gravity will always try to distribute the fluid to this area and this area, not to this area. As a surgeon, you can always do some steps to make sure that this, what you get. In other words, to work against the gravity. And that's what you obviously, what we call it perfect bleb. Perfect bleb is shallow bleb, not very elevated, very posterior, covered with the upper lid because of the risk of infection, obviously, and not going on both sides. Because any bleb on both sides near the limbus is risk for infection, risk for leak, and discomfort. So that's, you don't need. I mean, this, obviously, you need to do your best not to have it. You need to have this. And regarding the design of the flap, so if you just kind of try to reflect from the previous slide, if you make your flap really long on these two sides, and the length from here to here is more than the length from here to here, you will end up with side leak on both sides. And that's, as we said, that's the worst thing ever for trabeculectomy surgery. So that's what you want. That's the best. You need to make your flap from distance from here to there is definitely far shorter from here to there. So in other words, when the fluid is coming, rather than traveling all this distance to be drained from here, it will find that it's much easier if it goes from there. And that's what we call it the perfect blib, which is posterior, not on both sides and slightly shallow. And that's all the new technique now, or all the, let's say, the best technique, including the Moorfield safer surgery system, rely on this. The other thing which is very important, these areas here, the flap, should not go towards the limbus. So you should stop 1 to 2 millimeter, or even 1 millimeter, let's say, before reaching the limbus. Because if you reach to the limbus, again, you are inducing flow on both sides. So you need to stop before you reach to the limbus. And in this way, you will get this perfect blip. Again, trabeculectomy. Now we have a patient and we are sitting in front of the patient. So we need to think outside the surgery box. In other words, I have a patient who I think I need to do trabeculectomy for him or for her. But before going ahead, these are the things which I need to think about before I offer even the surgery. Consenting, and we discussed this before, managing expectation and ensure post-op care. That's very important. Then moving to examining the eye. Ocular surface, if this is inflamed, I need to calm down the inflammation. Otherwise, it will fail because fibroblasts are already there. They are ready. The plasmin cells or the inflammatory cells, neutrophils, they are very happy to come and cause all sorts of scarring after the surgery. So if I operate on very inflamed eye, okay, I may have good outcome, but not for long. And even if I have it for kind of longer than usual, it will fail at the end. So I need to calm down the ocular surface. And then you need to check the mobility of the conj, because you'll be surprised. Sometimes you have these conj, especially for patients who have been using bimatoprost or pilocarpine or brimonidine for many years. They may have very thin conj, and they may not be even good candidate for trap, or they may have immobile conj. If you have immobile conj, you will really struggle. And then lastly, you need to have look at the eyelids. If you have very stiff eyelid with deep set eye, and there is no way you can lift the upper lid to be able to do the maneuver after the surgery, even if you manage to do the surgery, there's no point of doing trabeculectomy, because you will be stuck. If this patient had if they had like high pressure, how can you remove the releasable sutures? How can you massage it? You won't be able to do much for these patients. So you can consider other options. Risk of hypotony, again, think about it. That's always in the background, obviously in my thoughts. And I don't like it in advanced glaucoma, as I mentioned before, because of the risk of wipeout. I hate it in uveitis. And it's always very high risk in uveitis. Any patient with uveitis, they are much more prone to have hypotony compared with other people. Either it's active or inactive. It doesn't matter. I'm talking about even previous history of uveitis. And I'm talking, I consider any patient who had previous cyclodiode the same as uveitis, because cyclodiode will cause uveitis inside the eye. So when I operate on a patient who had previous cyclodiode laser treatment, I deal with them as same. I do the same technique as uveitis. So again, here you need to be very careful. You need to make your flap thick. And as we mentioned, it has to be designed, well designed, as we mentioned before. and you have to put a lot of releasable suture, and don't remove them early. Keep them till late, and then you can remove them. Same with myopic patients, especially highly myopic, because they have thin tissue, and young patients, again, the same, and post vitrectomy procedure, and in addition to other risks, obviously. Not every patient who is having deterioration in their field, they have normal tangent glaucoma. Keep this in mind. So if I see a patient with the eye pressure of 10 on kind of multiple visits, and they are still having progression, it's very guarded prognosis, really. So I need to explain to them, and before I do any surgery, I need to do other tests or other check, mainly phasing. So I need to bring them on a long day, check their eye pressure every 2 hours for almost over 8 hours to make sure they are not spiking. MRI scan to exclude other pathology, as you may all know, blood pressure, blood test. I always include full blood count, ESR, CRP, in addition to B12, folate, and vitamin D. Vitamin D, B12, and folate, they are neuroprotective factors. And a lot of studies, they are linking these to other type of optic neuropathy, not only the glaucoma. So that's why if you have patients with very low vitamin D or very low folate or B12, these needs to be treated before you jump to the trabeculectomy if the pressure is already very low. Blood pressure, this is very interesting one. Blood pressure, it has to be checked over 24 hours, because if the patient is having drop during the evening time, while they are sleeping, and they are having very low readings of the intraocular pressure, so those patients are at very guarded prognosis, actually, and we need to treat this. And a lot of patients, they say, okay, we do the blood pressure check and it's low, but you can't do anything about it. No, you can. In these cases, you need to see why. So you need to check the adrenal hormone and see whether you need to give steroid if there is any deficiency. If there is no deficiency, see whether they are using the timolol in the evening. You have to make it in the morning. See if they are using any beta blocker tablets in the evening, switch it to the morning. And finally, if you can't do anything, and this is persistent low blood pressure in the evening, ask them to have salty yogurt before they go to sleep, and it can help. So in other words, you have to think not only the glaucoma, because it can be other things, really. Element of success, optimizing the ocular surface before the surgery, type of the anesthesia, surgical technique, and post-op follow-up. And again, we'll talk about it one after one within the next 7 slides, and then we'll show the video. So optimizing the ocular surface, if you see a patient with significant nasty blepharitis and very inflamed eye, I always, as a routine, I ask them to stop the elements which are causing the trouble. And in my opinion, it's pilocarpine, brimonidine, bimatoprost. I hate these drops. I don't give it to my patient at all. But sometimes you see those patients referred from other centers, or so I always stop them, and I give the patient low dose of Diamox if they can, if they have no contraindication, for at least 6 to 8 weeks. I start them, I think, in my opinion, this is possibly the most gentle combination for any patient who has glaucoma, which is the preservative-free Cosop or dorzolamide timolol and the preservative-free latanoprost, which is monopost. This combination, you will be surprised. I mean, most patients, I can't say all of them, they have white eyes, literally white eyes while having this combination. However, some people, they are allergic to timolol or allergic to dorzolamide, so they may still have issues. But always, I'm talking about the preservative-free. And SLT, I'm supposing it's already done. And I always give them mild steroids for 6 weeks before the surgery. And I try to choose steroids which is not causing the increase in the pressure. Like here in the UK, we have something called Softacort, which is the preservative-free hydrocortisone. And that's not penetrated inside the AC. So it's not known to cause high pressure, but it can work on the ocular surface. And that will, again, reduce the amount of the neutrophil and reduce the fibroblast proliferation after the surgery. So it can be very helpful. Most importantly, if I see significant blepharitis, I always give doxycycline and lubrication and ask them to do lid hygiene before the surgery. And if I see really a lot of discharges coming, it's not only that, I even give them topical antibiotic. And the benefit of topical antibiotic is not only to treat the blepharitis, to reduce the risk of endophthalmitis, because as we said, when you are applying mitomycin, you are exposing this patient to a risk of infection, especially if you are making this filtering surgery. So endophthalmitis could be nasty, and that's something you need to take care of it and try to stop it or reduce the chances from the beginning. And that's my usual protocol for most of my patients who have ocular surface disease, or if I think I need to optimize the ocular surface. And again, you will be surprised with the effect of doxycycline. Doxycycline works like a magic in these cases when they have really kind of bad meibomian gland dysfunction or very oily discharges. Talking about the type of the anesthesia, for me, again, if I have very advanced glaucoma, or if I have very short axial length, I should have GA, unless if there is contraindication. The reason why, because LA will increase the pressure more behind the eye. So if we give the patient LA and they already have very advanced glaucoma, I'm talking about really advanced glaucoma, I'm exposing them to wipeout syndrome. If I choose to go for GA, I ask the anesthetist for two things, which are extremely important. Not to have low blood pressure during the GA, because that's the worst thing ever for the wipeout syndrome, and always to have low CO2 during the procedure. Again, that's very beneficial. These two, they come together with any patient with very advanced glaucoma, and that can be extremely useful, really, and reduce the risk of the wipeout. If I choose to go for LA, I always ask the anesthetist not to massage or apply pressure on the eye at all. So just give the peri and then wait. It will work. You don't need to massage, you don't need to press, because any massaging, any pressure, you are increasing the pressure, causing more damage. No need. And lastly, don't forget to put the apraclonidine 1% to shrink the blood vessel and reduce the chances of having the bleed during the surgery. It works as a concept of adrenaline, but less risky. And I always put pilocarpine, which is obviously 2%. That's common sense to shrink the pupil. Now, the traction suture. Traction suture, I know it can be very straightforward, and possibly it's not, it doesn't worth mentioning, but I just wanted to mention a couple of things, because again, I had some issues with that at some stage when I started doing the trap. So I always prefer 12 o'clock. However, not always. If you have really kind of very thin tissue here, or if you have Delen or anything like this, there is no harm of doing it at 6 o'clock. It will still work, and very nicely and very beautifully. So either 12 o'clock or 6 o'clock. Go really deep and use a spatulated needle. I use usually the Silk 7.0, but you can use Vicryl as well, 7.0. Go almost up to 90% of the thickness, and you need to leave a gap between the traction suture and the limbus, because you are going to place your releasable sutures here, here, here. So if you come very close to the limbus, there will be no room to put your releasable. So you have to leave at least 2 to 3 millimeter and make it here. And then when you push or when you pull it and stick it on the drape, look for these signs. If you see the traction suture really pushing on the cornea and causing dip here in the cornea, so this patient will come to you next day with really a lot of descent folds, and they won't be happy. It will heal possibly, but it takes sometimes 2 to 3 weeks to heal. No point. So you need to tent it. So in other words, this traction suture need to be kind of hanged on near the nose of the patient, rather than just being kind of very flat and causing this impression on the cornea. And that can be really, it can take time for these descent fold or Bowman folds to heal. The other thing which you need to keep in mind, this traction suture needs to be released before you go into the AC when you are going to do the cut. So it can be kind of really firmly attached, but once before you go into the eye, it has to be released. Otherwise, the whole anatomy will be different. If while you are doing it, if you penetrate the cornea, if you go too deep and you see some fluid coming, simply go out and take another one. Because if you carry on, you will find after half an hour or so, the AC become flat and your eye will be, the eye will be very soft, and that can make your life very difficult. And if you decide to do it again after the eye becomes soft, it will be even more difficult. So from the beginning, if you see some aqueous coming from the other end here, go back and then put another one either here or there. Or if this is too shallow, so again, it will cheese wire. So again, go back and put another one. So it has to be the right depth. And I think it makes sense just to spend some time and obviously do it properly. Regarding the conj incision and the cautery, I usually start from here, as all the surgeons do, and then I go up to here, almost 2 millimeters away from the limbus. Here, at this area, anatomically here I'm talking, the conj will be kind of melted with the tenon. Once you reach to this area, you need to grasp both of them as one layer and dissect under the tenon. Don't dissect one and leave the other. So always grasp it 2 millimeters away once you make the initial opening, and then go under the tenon always. Again, that's, in my opinion, that's the ideal peritomy. That's one of my cases. So I'm just going to show you the video later. But sometimes you have to go really wider. And the reason for you to go wider, if you have a lot of bleed, you have to make large peritomy, because if you don't, and if you keep this bleed inside or in the pocket form without cauterizing it properly, the bleed is kind of pro-inflammatory. It will cause more fibroblasts while it's healing after the surgery, the subconjunctival bleed. So in other words, the mitomycin will struggle to work. So in patients who have very severe or like significant subconjunctival hemorrhage, really make large peritomy, try to clear all the bleed, do the cautery, keep pressing slightly to drain most of the bleed as much as possible before you apply the mitomycin. In my opinion, the subconjunctival bleed is the enemy of the mitomycin. So always try to do this and try to dissect as posterior as possible. No need to dissect here or there. There's no point, because as we said, this is the area which you would like your bleb to be there. So if you dissect here or there, you are kind of guiding the fluid towards this side. However, you have to decide to dissect here and there, not to go really far, because this area needs to be relaxed from the tenon to be able to close. So I would usually just dissect up to here and there on the sides. However, in the posterior margin, I'll go really to the posterior as possible with the Wiskott scissor. Applying the mitomycin. So a lot of people, they inject mitomycin. I personally don't prefer to inject for two reasons. First of all, even if you inject and try to massage, it's very difficult to get it in the plane which you would like to be, and very difficult to get it to where you would like it to be as well. Whereas if you make large peritomy and if you apply the corneal shield, that's the one which I use usually, you know exactly where you are applying it. And that's the corneal shield which I use. So obviously it will be soaked with the mitomycin. And then I go under the conj while I'm protecting the edges. So the edges will be like a tent. I remove it in the air, and then I go with the other forceps in the peripheral area. So as you will see in the video, I'm going to do, for example, my trap here, but I don't apply the mitomycin here. I apply it here and there, because that's what I would like the flow to be. I don't want to apply it here at all. And always protect the edges of the conj by lifting it away from the area. and keep drying it if needed, and then give it a good wash. I don't wash under the conch. I just wash on the cornea, and I wash the edges of the conch. I don't go under the conch and wash, because I prefer to have some concentrated mitomycin rather than washing it completely. Otherwise, there is no point really. Regarding the scleral flap, as I showed you before in the animation. So I start from here. I go really I try to go 70 to 90% depth. So I start not at the limbus, as I told you. I always leave a gap here, and always the same, leave a gap here, because otherwise it will leak from here and there. I don't want this to leak. So I go from there, I make the pocket, and then I I go from here, I make the cut, 70 to 90%, I make the pocket, and then I make the side cuts here on both sides. I'm not sure if you can see it here clearly, but that's the thickness which I would like to see at the end. I don't want to have very thin sclera. Thin sclera is a big risk for hypotony. However, if you have very thin sclera originally, like if you have a patient, let's say, who is myopic, and they have very thin sclera, I usually tend to make my scleral flap much bigger, because as we said before, the bigger scleral flap will scar more. But if I have very myopic patient and I make the scleral flap just tiny like this, and it's already thin, so the risk of hypotony is really, really big. So it depends whether you're operating on very myopic patient with thin tissue or not. If you think it's a lot of thinning there, before you start, you can make your flap not much bigger, I would say bigger. So possibly rather than 3 by 4, you can make it 4 by 5 millimeter. The shape, again, that's the shape which I use. Some people, American school, they use the triangle. I don't know, it's up to the surgeon, but in my opinion, according to the Moorfield safer system, this is possibly the best shape, because that will direct the fluid from here rather than from both sides. Whatever happen, even if you have bleeding from the bed here, don't ever cauterize the bed. If you cauterize the bed, if you touch the bed with the cautery, you are causing more thinning, more shrinkage. And then if you are going to suture it, this area will keep leaking. So if you have a lot of bleed from the bed, just be patient, put some phenylephrine eye drops or even iopidine, and just keep pressing. Give it 5 minutes, and then it will stop. If it's not going to stop in 5 minutes, it will stop in 10 minutes, in 15 minutes. But don't ever cauterize it, because that could be really bad news for the hypotony, and it will change the whole anatomy of the eye if this area is going to shrink or cause trouble. When you handle the flap, that's again very important. So when you grasp the flap, grasp it from the edge, because if you grasp it from here, and this is tooth forceps, and if you have buttonhole, it can be a nightmare to deal with here. But if you have some kind of thinning or buttonholing here, you can stitch it, so it's not an issue. So always grasp it from the edge rather than from the center. That's very important. As we mentioned before, small scleral flaps don't heal easily, only big flaps. And big flaps is more likely to scar. However, it can be useful in very thin sclera to reduce the hypotony. The releasable sutures, that's my usual technique. And I think that's the best technique really for any glaucoma surgeon, because it can give you the freedom of controlling things after the surgery and kind of keeping yourself and the patient on the safe side. So the technique is described here. You will see in the video, but this is just very simply to say. So you go one bite. So this is the tenno nylon. I go from here. Obviously, I make a groove in the cornea first, but I go from here in the depth. I go outside, inside the groove, and then I go inside the groove. Again, I go in the flap itself, and then last last thing, I go from the flap to the other side of the sclera. I think it will be easier with the video, but that's what you see next day after the surgery. So you will have 3 loops here if you do 3 releasable suture. And then I usually start with the middle one and then see if I need to remove these 2 later or not. So again, that's how it should look like. Very important tip here. You see when you put your releasable, because that's how it looks like. I usually put them and then I make the cut and everything. But to make sure that they will not be coming into my way, otherwise I may cut them while I'm doing the sclerostomy. So I do these loops, this loop and this loop. And that can be by just pulling everything from under the flap on both sides. So keep them away from the area where you are going to make your sclerectomy and iridectomy. Otherwise, you can easily cut them. And if you cut them, you have to replace the releasable on a soft eye after you open the AC, and that can be very difficult. And regarding the number of sutures, I think there is no number. The number usually, some people they put 2, some people they put 3, some people they put up to 6. It doesn't matter. What matters, you need to make sure when you finish your surgery that this eye is not soft, and on the other hand is not valving. So I'll tell you what is valving in a sec. The paracentesis and the sclerostomy and the iridectomy, that's the next step. So when you do the sclerostomy, this is usually the ideal size of the sclerostomy and the ideal location. So it has to be in the middle, because if you do it here, this fluid will migrate towards, as we said, the shorter area, which could be this one rather than this one. And the same if it goes to the other side. So it has to be in the center. And the other thing is, I wouldn't go beyond the gray line, because the gray line is here. So I go towards the edge of the gray line, but I never exceed it. Because if you exceed it with the sclerostomy, you can bite the ciliary body. And in many cases, you may get even vitreous loss here. So that's very important. When you do the paracentesis, I usually mark it. I'm marking it only by just making a small cut, which can ooze some blood before I go into the AC. The reason why, because once you do the paracentesis, and then if you would like to inflate the AC after you open the eye, where the pressure can be 0 and you have no time to waste, if you are not sure where is it, you will finding yourself kind of looking for it all the time, and you may not be able to find it properly. So it's always good to make a sign where you made the paracentesis to be able to find it easily. When you, before obviously you cut and go into the AC, test your punch, make sure it's working. And when you punch it, when you punch this area, you need to punch it at 90 degree, not kind of parallel to the limbus. It has to be 90 degree to the limbus. When you do the iridectomy, do it peripheral and deep. So you have to see the actual whole iris tissue, not only the epithelium of the iris. And you can easily see the reflex, like the retroillumination. And once you see the reflex, you know that you are doing the right thing. So this is, for example, the area, the sclerostomy, which I was telling you about the location. So this sclerostomy was meant to be here, but it was done on this side. So now the fluid can be sometimes leaking to this side rather than traveling to this side, because you created sclerostomy, which is closer to this edge. So that's why you make this as, rectangular, and this has to be in the center rather than being off center. This is another example of sclerostomy, which is really close to the edge, and that can be high risk for hypotony. So keep in mind, you don't have to come very close to the edge. I would say this is your margin here, up to here, if you have to. So possibly this one, I would say could be up to here, is better. So up to the posterior edge of the gray line, but no more. So you don't have to come here. Here is the ciliary body, and the vitreous will be sitting there waiting for you. So don't come to this area. And that's what I meant by vertical. So when you go into the AC to make a cut So you have to go almost vertical rather than horizontal. And the punch needs to be vertical as well, rather than horizontal or parallel to the limbus. And if you do it this way, the valving will be much less. When I say valving meaning when you end your surgery and when you tighten your releasable, you try to test it and you will see no flow. And that could be because the whole tissue is kind of closing each other or kind of covering each other. And this is one way to avoid the valving. Number 9, tightening the scleral flap. Again, you need to aim. What is the aim? Take your time, because this is the most important step of the whole procedure, really. Take your time, take 5 minutes, take 10 minutes. That's how you can obviously decide whether this trap is going to work or not. So what I usually aim, I aim almost for no flow or tiny, tiny oozing on the table. If I see more than usual oozing, I keep putting stitches or tightening the stitches. I don't want to see a lot of oozing, tiny oozing. And if you see no oozing at all, which is fine, but if you press just gently on the edge here or there, and you see some fluid coming, that's fine. So you don't have always to see oozing. But if you see tiny oozing, that could be acceptable. And again, when I said check for valving meaning you press here, and you don't see any fluid, no fluid is coming. And then that's because it's valving. The actual area here is not draining because the whole tissue is kind of covering each other or sitting on each other. And what you can do in these cases, so let's focus here. So you can do 3 things to stop the valving. First of all, you can try to release these stitches on both sides because sometimes they can be too tight, and retest. If you still see no flow, so you can go with the actual crescent blade under the bed and try to do some movement, because sometimes it can be blocked with the clot or tissue or scleral tissue. It can be a lot of things. And if these 2 maneuvers are still not working, so unfortunately you have to remove these, or not remove, I mean like relax the releasable and go to the edge here and make the cut slightly more peripheral towards the limbus, because that can stop the valving from happening. I know that there is a risk of having more flow on the sides, but it can help in releasing the pressure coming from the flap on the tissue underneath. Valving is much more common in thick flap. It's not common at all in thin flap. So if you make really nice thick flap, it can valve. And valving meaning this patient will have very high pressure for a few weeks after the surgery, unfortunately. So we have to make sure it's not valving. And as we said, that's how it works. So in this case, for example, I had to remove the stitches and then go more peripheral to be able to reduce the valving. This is another example of some other cases where you may need to put a lot of stitches, not only 1, 2, 3, many stitches. So this was very thin scleral flap. So a lot of stitches has to be put in. You just keep putting. And sometimes if you have, again, very thin, still leaking, sometimes you have even to apply patch graft really on the area, because if this is very thin tissue, you will end up with hypotony. There is no point of closing your eye and say everything will be fine. It won't be fine. If on the table things are leaking, it will leak next day. There is no way you can avoid this. Lastly, suturing the conj. So you have to obviously suture the conj with 2 purse sutures on both sides. And the aim of these purse sutures is just to bring the whole conj and make it kind of tight at the end. And then you can put the mattress sutures here. So the mattress sutures are just meant to stop the conj from retraction rather than bringing or fixing things together. It's meant to be these 2 purse sutures to make the conj kind of flushed against the limbus. If you finish your surgery, let's say this case, this was one of my cases. I finished the surgery. I thought I did a great job, but then at the end, I touched the eye. The eye was quite soft, very soft, despite everything I did. And then I saw this huge blip form. So really, it was GA patient. The surgery took a while. I was under pressure because there was another case coming and I had to finish the theater list. Nurses were not happy, but I had to take the decision. So I just kept like thinking about it. I took my time, 30 seconds to think. I breathe, and then I decided just to open up everything and fix it. Because what's the point? This patient will come to you next day with shallow AC and pressure of 1, and you have to take them back to the theater. So fix it just on the day. You have the chance to fix it. I know it's very stressful, but sometimes some signs you can't just close your eyes and say, no, I can't see this. No, you have to see it, unfortunately, to be able to deal with it on the day. So this is the video, which will summarize the steps which we talked about. So this is the traction suture, as we said. So I usually go with the wavy movement, up, down, up, down, up, down. And I just try to push rather than pull, because pushing is less traumatic to the cornea. And then once I reach to the end, and then I pull. As you can see, this is the distance, which is obviously typical in these cases. And then the next step will be to do the conj dissection and the cautery. So I make the cut, and then, as we said, 2 millimeter. Once I reach to 2 millimeter, I cut everything. I just dissect. And then I cut at the limbus. And then I use the other forceps and go really posteriorly with the dissection, as posterior as possible, mainly from here to there. I'm not interested in this area or this area, unless if I have strands of tenon, because otherwise it won't close, so I can just dissect them. And then I do cautery. Regarding the cautery, you have to be careful. Don't over kind of heat the sclera, because you will end up with thin tissue. So just do it gently and make sure you are kind of having decent area. And then apply the mitomycin. As we said, with the mitomycin, I use the corneal shields, and always my technique is just to lift the conj edges to make sure the edges will not be exposed, and I go and really insert it in the periphery. So I used to use only 2, now I'm using 3. So I'm using 1 here, 1 there, and another one there here. But can you see how far it is from the actual bed of the sclera? And then I wait for 3 minutes. And then I remove the whole thing, I wash it. And then here just to show you how I make the cut. So I estimate the depth under the microscope. I'm aiming just to see very kind of faint reflex of the choroid, not obviously to see the choroid. It's almost 90%. And then I go with the crescent. Once I make the initial cut, and then I move the direction of the dissection, I go almost parallel to the limbus. I make the pocket, prepare it. It has to be thick, nice pocket. And then I make the side cuts on both sides. So as we said, not to the limbus. And here, unfortunately, had this patient just like had this bleed. All you need to do is just wait, and it will be fine. So you see how thick and nice is the flap. So it will stop. Don't worry about it. I'm holding it from the edge, not from the bed, as we said. So I'm preparing the releasable now. You see how it is. So I went from here to this groove. I made a groove here in the cornea. And then all you need to do is go partial thickness here. Don't go full thickness because of the risk of buttonholing. So when you go partial thickness from here to there in this edge, as you will see now, partial thickness, again, partial thickness. So that's the first releasable. Same thing on the other side, exactly same technique. And then I make these 2 loops, as I told you, because I don't want these to be in the way. I make the paracentesis. And then this is the punch. I test it always before I open the AC, because the last thing I would like to have is the punch is not working. I go vertically, make full thickness cut, and then I do the punch vertically as well to prevent or reduce the chances of valving. So yeah, so that's possibly enough size. And then you have to do the full thickness iridectomy, which is the standard one. And then you have to fill in the AC, very important. And then all you need to do now, because it's pre-placed, the releasable, so all you need to do is to tighten it. It's four throws, and make it really tight. So on one side, do the same on the other side. Again, make it tight. And in theory, you finish your surgery here, because that's the most important bit. But obviously you need to, as I told you need to spend time to check for valving or over leaking. So you re-inflate the eye again with the water, always water. I don't use Helon at all, because it will change the physiology of the, and I aim for tiny oozing or no oozing at all. So keep inflating it, check the pressure, make sure the pressure is not too high, because if the pressure is too high, you will have some oozing. So release the pressure, make sure almost it's physiological pressure, let's say between 20 to 25, and then you can check for the oozing and these things. And always lift this conj away from the area, because if you keep it sitting here, the conj itself, it will ooze a lot of fluid. So when you check with the spears, you won't be able to tell whether this fluid is coming from the conj or it's coming from the scleral bed itself. So here in this patient, it was valving slightly. There was no leak at all. So I had to release the suture slightly, and then it was okay. And then lastly, sorry, I will show you the suturing the conj. So this is the purse suture. You can either use nylon or Vicryl, it's up to you. So you go one good thick bite, and then you do 2 to 3 in, out, and then you go in again in the conj. Now, the benefit of this technique, it will make it watertight. If you do one on each side and bring the conj anteriorly, in theory, it should be almost watertight. So you cut it and then you suture it. You tighten it, sorry. Make sure it's watertight. Do the same on the other side, and then you do 2 or 3 mattress sutures here to make sure it won't retract in the future. So yeah, so these are the mattress sutures here after I did the other one there. So you go limbus first, and then you go into the conj, and then out of the conj, and then stitch, which is the traditional technique actually. Always don't try not to grasp the needle with your forceps. Never, because it will cause damage to the needle and to the forceps. Always use the needle holder. The last step is always to give the injection and test with the fluorescein to make sure it's not leaking at the end. Almost the last 2 slides, and then we'll finish. Sorry, I know it's Sunday evening. So a couple of things to think about. The post-op regime, what I usually do, I always give preservative-free drops, give antibiotic preservative-free. In the UK, they use the chloramphenicol as a first line, 4 times a day for 2 weeks. And the DEXA-free which is the dexamethasone preservative-free, I start usually every 2 hours for 2 weeks and then bring it down to 6 times a day for a month and possibly start to reduce it gradually, extending the regime between 3 to 4 months after the surgery. If I see very high risk for failure, I'll go for prednisolone acetate, which is the Pred 40. I know it's not preservative-free, but it's far better in terms of fighting against the neutrophil and the inflammation. The other thing is for the injection, I don't tend to give 5-FU before at least 1 to 2 weeks after the surgery because it's not going to work. 5-FU works mainly on the fibroblast. My preferred option, week 1, if I see a lot of inflammation, is to give subconj dexamethasone, because dexamethasone will work on the neutrophil and the plasma cells, and that's what you have usually during the first week after the inflammation, after the surgery. And always don't forget to give lidocaine subconj before giving it, because it can be very, very painful to the patient. 5-FU you can start giving week 1 or even week 2, depending on the situation. I can give 2 or 3, depending on the situation. If I give 5-FU, I always wash the cornea very nicely, because 5-FU is very toxic to the cornea. I don't remove the releasable sutures before at least 3 weeks. However, there are very rare cases which you may need to remove before that, but 3 weeks usually is very low risk for hypotony compared with other people. However, if this is very myopic patient or uveitic patient or other things, other risk for hypotony, I may even extend it more. Again, regarding the consideration, hypotony, we already talked about risk of endophthalmitis, which is obviously very significant risk. And that's something we need to observe and keep an eye on patients, especially in patients with high concentration of mitomycin and immunosuppressed patient. Astigmatism is very common in young myopic patient, or if the trap is superior nasal. Keep in mind the astigmatism can be irregular, and that's something you need to tell all the patient about, especially in a young myopic patient. If you are going to do cataract surgery after you do the trap, usually at least to give it 6 to 12 months after the surgery, and still there is a chance of 20% of failure of the trap after any cataract surgery. I used to give 5-FU, and now I'm switching my practice, giving mitomycin after the cataract surgery rather than 5-FU, and I give it in the fornix rather than in the conj itself, because of the risk of the thinning. So I give it in the fornix, and I give long course of steroids treatment, at least for 3 months. Hypotony, we talked about, can be early, can be late. If this is early, all you need to do is either reduce the steroids, inject Helon, and see. If this is not fixing itself, you have to revise the patient. If this is late, you have to do revision, and most likely with patch graft if this is serious. Can be benign. Benign meaning only digital hypotony, so numerical hypotony. Hypotony by definition, if you have pressure less than 6 in 2 different visits. So if you have numerical hypotony, you can just keep observing. It doesn't matter, especially if the macula is okay. However, this will cause definitely astigmatism and some inaccuracy of any biometry in the future, because the axial length will be less. If this is serious, you have to deal with it. And in uveitic patient, actually, there is a very nice tip here, which I learned from Prof. Keith Barton. So if you are giving Helon to the patient for hypotony, always give it tangential and at almost near 12 o'clock. So the main point is, if the patient is going to move their eye on the slit lamp, you will not hit the lens because you are far away from the lens. And always make it tangential, so you will be in complete control on the slit lamp. However, if you have patients with uveitis, and if they have hypotony after, let's say, a few months or even years of having trap, and if you don't see diffuse blip, you will be stuck. Is it ciliary body shut down, or is it overfiltrating blip, which is not showing or significantly? In these cases, there's a very nice tip. You can inject some gas, but this time, rather than being here, it has to be injected at 6 o'clock or near 6 o'clock. And send the patient home, ask them to come back after 1 day. If you see a lot of bubbles under the conj, so the hypotony is related to the filtering blip. It's not related to ciliary body shutdown. But if you can see any, like if you inject SF6, for example, if you can see any air bubbles under the conj, so this is most likely ciliary body shutdown. And this trick can be used not only in late hypotony, it can be used if you are not sure, if you can't see very diffuse blip, even at early stage. I think this is the last slide. Endophthalmitis post-trap, it's definitely 10 times more compared with phaco because of the mitomycin. If I see a patient with ischemic blip like this, thin and ischemic blip, I always give them a warning that they need to come to eye casualty should they have any signs of redness or pain. And I ask them to keep in their pocket or in their bag always antibiotic and start using it whenever they feel the eye is gritty or painful or red, because that can progress in a very bad way compared with after phaco, and the organisms seen are even more invasive compared with phaco. And that's why it's very important to tell them about this. People at high risk of endophthalmitis are avascular blips, blepharitis, and immune compromise. So if you have these three together, those patients will definitely be at much higher risk compared with this figure to have endophthalmitis or blebitis, which can turn into endophthalmitis. If you see blebitis, which is like, for example, like this, and if you see any cells in the AC, treat as endophthalmitis, definitely. And that's another reason for me not to inject the mitomycin, and rather than I just apply it, because injecting it can cause this localized ischemic blip. So in conclusion, why do we need to know every single tip in trap surgery? It is unpredictable, unfortunately. In many cases, the outcome depends on many factors, including the surgery, the technique, the post-op, and the healing process. It's not a pleasant surgery to the patient. So that's why you have to try your best to reduce every single chance of complication. Minor surgical changes in your technique can make your post-op far better or far easier. So these things, I know it's tiny things, but believe me, sometimes it can make the follow-up far easier. And yet, despite you do everything, don't always expect perfect outcome. You have to be realistic, explain to the patient, and take the decision according to the joint discussion between you and the patient. Thank you very much. Thank you, Dr. Mazen, Dr. Bassel, and all the attendees.
Thank you so much, Dr. Muneer. A very comprehensive, very neat, talk. Thank you so much.
Thank you.
Before I started, I have some questions, but I think you've answered all of them. You've spoken about every single detail in the surgery. You've taken us to the world of trabeculectomy very deeply, We have 3 questions from the audience. We start with the first one from Ricardo de Souza Big Soto. About the pre-op optimization of the ocular surface, Dr. Ricardo gives the patients Ikervis, cyclosporin 0.1%, 1 month before the surgery if he sees MGD. Do you have any experience with it?
Yeah, actually, first of all, hi, Ricardo. Thank you very much for your question. I hope you are well. Ikervis is definitely a good option, but my understanding, Ikervis will take more than 6 weeks to work. So if you give the Ikervis, you usually start with the steroid anyway, and then you can always stop it, the steroid, I mean, after 6 weeks, and then keep the patient on Ikervis. I myself published one case series about using Ikervis in a patient who have been using the eye drops for glaucoma and have intolerance to the glaucoma. So in almost 10 out of 10 of cases, we managed to keep them on the drops with the use of Ikervis, but it took time to work. So it definitely can be a good option if you are not in a hurry to do the surgery. So if you are having like 2 to 3 months, you can start them on this and it can help a lot. But I think if you have only like if you are listing them for urgent surgery, possibly steroids could be the best option.
Very nice. And in the case of the group of patients you mentioned, those who have intolerance, how long do you continue with the Kervis? Usually we do it 1 year, but in this case, the treatment is lifelong. So how much do you continue with the Kervis?
I think Kervis, once you start, you have to give it time. So usually at least 6 months, and then you can reassess. If the eye is fine and the patient after the surgery is healing nicely, you manage to stop all their treatment, the anti-glaucoma treatment, I think you can stop it. Just keep them on lubrication and they should be fine. Unless if they have persistent symptoms, you can always extend it more. But Kervis, keep in mind, Kervis, if you have very kind of, again, slightly thin bleb, Kervis is a source of infection because it suppresses the immune system in the eye. And that's why possibly I wouldn't extend it more if I can.
Thank you. Faiz has a question. If your patients with a previous shunt glaucoma operation, which location of your flap do you prefer?
So shunt, you mean a tube?
Tube. I mean, he means a tube, a previous tube operation, and now you're planning a.
So very rarely, very rarely you face this when you have, because it's always usually the opposite. It depends what was the reason to have tube in the first place. If they had tube because the conj was not mobile, or if they are high risk, I wouldn't even offer them trabeculectomy. I may go for another tube, or nowadays we have the Preoperative, which in my opinion, from my experience, it works really well in cases where you can just avoid doing the tube in these cases. But if the tube was done for other reason and the conj is mobile, so my preferred option obviously is just to go almost superior nasal, despite the fact I don't like it superior nasal, but you can always try, but definitely not inferior. Inferior is a big risk for infection. So I wouldn't even offer trap inferiorly at all.
Very nice. Dr. Faiz continues his question, or in case of an eye stent or other devices, he means the location of the trabeculectomy or the flap. Does angle surgery, differs the location or makes you choose a location, not the other?
No, it has nothing to do at all. Because if you are doing filtering surgery, which is obviously involving the conj, it has nothing to do with eye stent or hydrus or these things. You can just go ahead, because usually with the eye stent and hydrus, you are putting it nasally, which is far away from the superior 12 o'clock area.
Very nice. I have a question indeed. You mentioned very nicely how to avoid the wipe-out syndrome, one of the most dreadful complications. I think Augusto Blanco published a paper about, overview about it. What do you think about the subtenon anesthesia in those patients? You don't want your patient to have pain under surgery, and many of our glaucoma patients are disease patients. So sometimes you can't do the general anesthesia. So what do you think about this subtenon in those cases?
Yeah, definitely. I think if the patient is not suitable for GA, that's could be an option. The only issue with subtenon, if you end up with a lot of chemosis or even subconjunctival bleed, you will be stuck here. And it happens many times, especially people who are on aspirin or elderly people. So, I mean, I can remember one case which happened when I was doing kind of my training in Coventry before. We had subtenon, which ended up with complete kind of subconj bleed and kind of elevated hematoma. So we couldn't even open the conj, we couldn't do the surgery, but it is definitely an option. The other thing with the subtenon, when you do the iridectomy, the patient will feel it slightly, definitely. But if you do the peri is more kind of suitable for these cases, and it will keep the eye very quiet without having any issues. And you don't have to do the massaging, you don't have to do the pressure. So it can still be suitable, but without doing the massaging or the pressure. So my preferred option is peri, but if peri is not working, subtenon could be an option, but I don't prefer it because of the risk of subconj hemorrhage, the risk of ballooning, and the chemosis, in addition to the last risk, which could be when you are going to stitch your conj. If you have very stretched conj, you may sometimes.
In the first week.
I know some people, they use it. They use Avastin post-op subconj, or I don't usually. And I think, I'm not sure about the evidence about this, because there was a recent conference which mentioned about this, and I don't think there was clear evidence to support using it on a routine basis. But some people believe that it can help, but it's very difficult really. From now till we have RCTs, it's very difficult to tell whether there is any benefit of using it. But you can, why not? If you have very inflamed conj, very severe ocular surface disease, possibly it can help.
Very nice. And we have one question from Dr. Faiz again. How do you see the place of non-penetrating deep sclerotomy comparing with trabeculectomy?
I think one of my colleagues in the department, she does the non-penetrating surgery, but she does it in a slightly different way. She combined both together. So she, in a way, she has the kind of almost filtering area coming from the non-penetrating area. And then at the end, she still goes into the AC. Her thought is she's creating two pockets. Anyway, I think if you asked Prof. Tariq Sharawi, for example, it definitely, in his hands, it's worked perfectly. And he can even offer it nowadays, according to my understanding, to moderate to slightly advanced glaucoma. But I'm not sure really, in my case, I haven't been trained to do it. And I'm not sure about the long-term outcome in advanced cases. So for example, now I'm switching completely towards Preoperative for mild to moderate cases, because I'm finding Preoperative far less invasive, very predictable, and obviously complication-wise, you can always deal with it in a less invasive way. But for cases with advanced glaucoma, I have no experience. I can't really tell whether non-penetrating will do the same thing. But still, in my opinion, according to most RCTs, is usually the trap is the best option here in these cases.
Yes, very nice. I don't think we have any other questions. I don't know if Dr. Mazen have any comment or any question about it. But I think, Dr. Muneer, you've covered very nicely the complexity of this simple operation, you know.
Thank you very much for being with us today, Dr. Bassel. Really, it's nice to see you after all these years anyway.
Yeah. Me too, indeed, me too. I told Dr. Muneer before you came, Dr. Mazen, that I met him with one conference in Syria when Professor Doua and others came to the British Syrian meeting, I think 2011, 2010, something like this. And I asked him some questions about practicing in the UK, you know, and about he was doing his PhD with Professor Doua then. Very nice to meet him again after about 10 years now, 11 years maybe.
Thank you.
Yes.
Thank you very much. Thank you.
Thank you very much, both of you, for this excellent session, this exceptional session, and for covering this very practical and surgical tip. I'd like to thank you all as the attendees as well for being with us. It was a long session, so thank you, Dr. Muneer, for being so patient and for giving that much of information. Thank you, Dr. Bassel, for such a wonderful moderation. And hope to see you all next time on December, inshallah. Thank you very much. Now, Dr. Bassel, don't close or don't leave, because I gave you the host. So maybe the recording will be downloaded on your desktop. So, okay. So stay, please. And I'm going now to close from my side to check whether I'm going to have it done on my laptop or maybe with you. Okay.
Okay.
Allah. Yalla. Assalamu alaikum, everybody. Assalamu alaikum.
Thank you. Bye.
Bye-bye. Take care. لا أظن غير الهوست اللي عندك دكتور، أنا كتبوا لي ضمن المحاضرة. انه انت الهوست. انت ميوتد دكتور، ميوتد، ما سمعك.
ايه اخي باسل،
إيه.
يسلموا ايديك يا رب. خلص مشي
إيه.
الحال،
الله
الريكوردينج عندي
مش
هون.
الحال؟ تمام تمام.
ممنون،
السلام
شكرا
عليكم.
جزيلا. تصبح على
مع
خير.
السلامة. انت مع السلامة.